Brian, please take us through another hinge joint. We're going to move up to the elbow and show us your manual context for applying a lateral glide at the elbow.
Goody. All right, the elbow, as Don said, is a hinge joint. And the first thing you should try is a lateral glide. And to do so, of course, you're going to be right up where the joint is, right on the joint margin, right up where the ulna is before it articulates with the humerus. And you've got to have some fixation above. And so I'm going to lodge my hypothenar eminence, if you like, on the lateral epicondyle. Can you feel that on the condyle? Now, let's say Jules has pain when she gets, say, to 90 degrees and she's lost movement. I will stand here and I will translate the radius and ulnar, the ulnar and radius across. When you push the ulnar, it must influence the radius. And if it's uncomfortable, I could use some sponge, but I won't need a sponge now. Now, can you feel that repositioning?
You're using, may I ask, you're using the side of your index MCP
because it's more specific.
Yeah.
That is soft, and that's right on bone.
Yes.
And I feel,
so you got
that's
the ulna.
effective.
You've got the ulna, don't
yes,
you?
I've got the ulna. I can feel it right there.
Okay.
So I reposition. Now, she must move slowly again without pain. And when she gets as far as she can, she gives overpressure.
I see your hand moving. That's nice.
Yes.
Okay.
And there's the overpressure. And I keep that pressure. Now let go. Now come out. Pressure maintained, and that's it.
Okay.
If that was effective, let's say I do this and it's better, but not quite good enough. It could be that you've got a great big rugby player like one of New Zealand's All Blacks, and he's got forearms like my thighs. And I'm pushing on there, and I'm getting caught with all the blubber. So you use a belt. And a belt makes it effortless. You can deal with all sizes of patients. But do remember, when we start using a belt, you can get a tremendous amount of force using your body and using a belt. And therefore, you've got to use some discretion. Now, we're going to get Julie to lie down on a bed, and we're going to show you the belt.
Just before we do that, could I just have you put your hands on one more time? And one of the things that you're doing, we didn't talk much about your left hand, because what it's doing on the distal humerus is it is just a counter force to this hand, so that we have a glide between the humerus and the radius and ulna. And in order to find that you're doing the glide in the correct direction, you're heading towards the epicondyle, aren't you? The lateral epicondyle, with your force.
Having raised that point, we were stupid. We should have, while we're here, shown the manual way of testing for, seeing if it's applicable for extension.
Okay, go ahead and try that.
You weren't included in that. Now, here I am. I've got Julie's arm in my axilla, if you like. Same positioning. I translate across, get Jules to come up, and because she's there, I can almost give...
You can give a good overpressure.
Give a good overpressure.
Yeah. But don't you have to be careful, because then you're giving the overpressure rather than the patient, and it could be painful. And then it would be your fault rather than hers.
I watch my patients carefully, and I tell them not to let me hurt them. And look, we're on this before we get her lying down, because she'll probably have a job waking her up. We also, it's a hinge joint. We've done translations medially and laterally. Please, if that's not working, try a rotation. In other words, grab up approximately as far as you can the radius and ulna and rotate.
I see.
Either externally or medially. Here's your fixation above. And while you're doing that, and it took me years to introduce, for me to use rotation in the elbow. I can't believe I was so stupid. I was using it in the knee and in the fingers, in the wrist. And on one occasion, I had two physiotherapists who couldn't extend their elbows or do anything on a patient without pain. And I said, oh, we'll have a go. And I tried the medial and lateral procedures and got nowhere. And I thought, oh. And I was sort of looking, in frustration.
So show me that one more time. Yeah.
Okay. That feels better. I said, of course. They didn't know that I'd never done it before. But
so you're doing a supinatory rotation here and a counterforce.
A counterforce there.
On your
or
top
you can
head.
go the other way.
Or you can go the other way.
Yep.
Depending upon the symptoms.
No pain, instant result, and
the repetitions, etc. How would you do that? What's the grip for flexion, please? How would you grip that, and how would you alter your proximal grip?
We've just done.
With rotation.
Oh, I beg your pardon. Yes. Well, You knew it'd be awkward.
I thought I'd put you.
There it is. Or I can go this way. Actually, you can feel that's quite effective.
Sure.
But look, now we're on that. Can I just talk about the olecranon process?
Absolutely.
Oh, please. You know, for years, if you look at textbooks and you treat human beings like we do, or animals, there's a lot of literature on the patella tracking. The patella in the knee tracks through a nice, neat sort of concave surface on the lower end of the femur. I now regard the olecranon process as a patella, and it fits snugly into the olecranon process. Isn't it conceivable that with a little bit of some irregularity in the placement of the bones here, that it doesn't fit snugly? And therefore, if you've lost flexion and extension, for instance, you should try repositioning just the olecranon process. And it's done with your thenar eminence right there. You just push across and see if they can extend. If that doesn't work, you use your other armpit and push across and see if they can extend. If you're doing flexion, you're up here, bend up, and you give the overpressure. Or I can go laterally. Jules bends up.
And that last one, now you're pushing it into, again, a pronatory.
Yes.
And a supinatory
it's almost
rotation.
doing this with a little bit of this. And when it works, the patients can treat themselves. They can push using their thenar eminence on the olecranon process. I think you could cope with that. And take it across. These fingers come up a bit. Move that across. And they say, I've got no pain.
So you don't show them that until about the third or fourth visit, so you can see them for a while.
So we can see them for a while. Yes, we're not stupid.
Okay, good.
And Jules can use her fingers to pull it across. But can I? No, we don't need to look at a skeleton.
No.
All therapists know their osteology, and they know how snugly that fits into that process.
Yes, what we should go to is probably showing it on the table with the belt.
Yes.
Brian, would you, as we go into applying this lateral glide with the belt, perhaps you could show how you would get the patient in position and start applying this glide?
Yeah, of course I could. All right, as you can see, the patient's lying on their back. If you were nice, you would have given them a pillow. And you place a belt around your hips and on the lower arm. Now, that belt is going to translate the ulna laterally and take with it the radius. If I am going to translate the ulna across, I must have fixation. Otherwise, the arm comes out from the side. So what we do here is to place a hand within the belt, and I will fixate either with my hypo or hypothenar eminence, or thenar eminence. There's the stabilization. And now I'm going to translate laterally. Now that belt must be parallel with the floor because the surfaces have got to translate perfectly. And if the belt is down low, I'm impacting the surfaces. And if the belt is up too high, I'm not doing a translation, I'm sort of doing other things.
Distracting a little bit. Right. Yeah.
So throughout the entire treatment, other things must not happen. That hand is up in the air. That's at right angles with the bed. So and it must not be here.
So the vertical forearm, it's held vertically, and the belt is horizontal for that right angle is what you were talking about.
Now, if that was there, that's not going to translate.
Right.
It's just going to jam the surfaces. And that's here. That's stupid. Look what happens.
Yep.
So that must be right up in the fold of the elbow. There's my fixation. And I always have the palm facing the patient. And she will look at her palm and predict her future. Now, there's the translation. Now, you can get tremendous power, and you mustn't.
Right.
You must feel that you've got some movement there, and so does the patient. There must be no pain. Now, if the patient said that is not painful, they will extend their forearm. Now, as they come into extension, can I just digress for a moment? When the arm comes down to the side, that's good. And then suddenly it comes sideways. A carrying angle improves. So you can see that properly on the screen. There it is, nicely there, and out it comes.
Yes.
Now, to maintain an accurate translation, you keep pulling laterally, down, 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 and when that carrying angle appears, I rotate my hips ever so slightly.
I see your hips moving, yes.
Ever so slightly. If I go right round, that's stupid. I'm going to impact the electron process on the lower end.
Changes the pull.
So again, you need a handling skill. You need knowledge to know what's happening. You've got to know there's a carrying angle. All those things are pertinent. There's the repositioning. Now, as it comes down, there's a tendency for people to do this.
That's an abduction of the shoulder.
Yes, and if they do any abduction, you've lost the translation.
Right, and certainly your angle has changed because the angle of the translation, isn't that midway between the two straps of the belt?
Yes, the actual force on that elbow isn't through there or there. When the two of them are pulling, you bisect that angle, so it's to my tummy button.
Right.
Good.
Is that in the middle?
Yes, yes. Yeah. I haven't been to a plastic surgeon yet. I don't need to. Good. There we are. My wife, I shouldn't say this, but my wife has me having face drops to make sure I keep looking older. I don't get a facelift, I get a face drop. But anyway, on we go. Down, 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 down. I'm keeping that in both sides. And at the end, it comes out, and I rotate slightly.
It's just at the end of the movement, isn't it?
Yes, the last 10, 20 degrees.
I see a lot of participants.
Do it straight away.
Yeah, that do it too early.
And it's wrong.
Yeah. Okay.
Flexion. When Jules comes into flexion, how far does that bone at the elbow move the ulnar? Probably an inch, 2.5 centimetres. So that as she's coming up into flexion, there's the pressure. As she comes up, I just move about an inch with her, but not 3 inches, because that'll give you an oblique distraction.
Right.
And if I don't move at all, you've lost it. So your treatment plane's important, and you must not lose it. You've got to have handling skills and some sense of feeling. So that's there, that's there. Up it comes. Absolutely great. Jules doesn't give over pressure. I do.
Would you just do 3 repetitions into flexion and 3 repetitions into extension, as I mentioned a couple of key points?
Yep. Okay. Of course I will.
Yeah. The first key point is that the belt is not so you can pull harder. Okay. Yeah. It's for an extra hand.
Yes.
And so we're keeping this forearm vertical. And if the belt pulls you 1 millimeter that way, this hand allows the distal portion of that forearm to travel 1 millimeter that way as well to keep its vertical alignment. Second thing, other than the strength of the pull, is that the movement is free on the part of the patient. And the key there of keeping the glide proper, it's always, as you monitor symptoms with your patient, that as long as it's symptom-free and a free movement, then you're doing it properly.
Which I was.
Yes, absolutely. She didn't complain once. She thought about it.
She thought about it. But it can be so successful. It really can. And if that doesn't work, get them on the side of the bed, grab the forearm and try a rotation.
Okay.
And they must not go out of your rooms.
Just one other point. That as you were putting on that glide, go ahead and show me that setup one more time. Does this belt ever get pulled inappropriately by the hand? Do you put it inside the belt, outside the belt, or does it really matter? It looks like it's altering the angle of pull.
Yeah, it's more logical.
Looks better inside the belt?
Yes. Okay. I find if you're outside, imagine if you're trying to get outside the belt here. Look what you've done to the belt. If you're trying to do it here,
right,
you've lost
absolutely
that distraction.
Okay, just wanted to clarify that.
Clarify that. I knew you were getting it wrong.
Yeah, I'm changing a lot of things after this.